She was sitting in her kitchen, morning coffee still warm. Her husband, 72 years old, reached for the sugar bowl and dropped it, his speech slurred, his right hand limp. She thought he was just tired. She thought maybe it was his blood pressure again. So she waited. 30 minutes passed, then an hour. By the time the ambulance arrived, the damage was done. He never walked again, and his voice never came back. How many more times does this story have to repeat before we recognize the signs, before we act? Stroke doesn't knock on the door. It strikes. Fast, quiet, ruthless. And the difference between life and lifelong disability can come down to minutes. You might think this won't happen to you. But here's the truth. After the age of 60, stroke becomes one of your biggest health threats. It doesn't care if you're active. It doesn't care if yesterday you felt fine. But what if instead of confusion and panic, you knew exactly what to do? What if you could look at your loved one and spot the warning signs in seconds? That's what this video is for. By the end, you'll know how to recognize the early symptoms of stroke, how to respond with confidence, and most importantly, how to protect your brain and your independence. Because every second matters, every decision counts, and you might just save a life. A stroke isn't just a brain attack. It's a sudden crisis where your brain is begging, sometimes silently, for blood. You see, your brain doesn't store energy. It needs a constant supply of oxygen and nutrients delivered by blood. When that flow is blocked or interrupted, even for a few minutes, brain cells begin to die. And unlike a sprained ankle or a pulled muscle, your brain doesn't heal the same way. When a part of the brain dies, the skills it controlled, speaking, walking, remembering, can disappear, sometimes forever. That's what makes stroke different. It steals without warning. It doesn't cause pain at first, but it leaves damage that can last a lifetime. Instead of thinking of stroke as a rare emergency, think of it as a silent thief, one that targets the part of you that makes you, you. But here's the good news. If you understand what's happening and act fast, you can stop it in its tracks. So what exactly causes a stroke to happen? There are two main types of stroke, but most of the time, people only remember one because it's the one that happens most often. The first is ischemic stroke, caused by a blockage. Think of it like a clogged pipe. A clot, or a buildup of fatty plaque, suddenly stops the flow of blood to a part of your brain. And without blood, that area begins to shut down within minutes. This is the most common type. Roughly 8 out of 10 strokes are ischemic. It's the kind we'll spend the most time talking about because it's the one where acting fast can truly change the outcome. The second type is hemorrhagic stroke, caused by a burst. A blood vessel in the brain ruptures, leaking blood into areas where it shouldn't go. This creates pressure, damage, and swelling. It's like a dam breaking inside your skull. Hemorrhagic strokes can be devastating, and they require different treatment, but they're less common and usually more severe right from the start. So instead of mixing the two, think of stroke like this. Ischemic means something is blocked. Hemorrhagic means something broke. Either way, blood can't reach parts of your brain, and that's where the danger begins. But where do these blockages or ruptures actually happen? Let's map it out. Your brain is fed by a network of arteries, a delicate branching system that works like highways delivering oxygen to every corner of who you are. At the center of this system is something called the circle of Willis. It's like a roundabout that connects the front and back roads of blood flow. From here, 3 main arteries branch out to cover different areas. The anterior cerebral artery runs forward and upward. If it gets blocked, you might lose strength in your legs more than your arms. Strange, isn't it? But that's how the brain is mapped. The middle cerebral artery, the most commonly blocked, affects the face, arm, and speech. If someone suddenly can't speak or their face droops on one side, this artery may be the culprit. Then there's the posterior circulation, fed by the vertebral and basilar arteries. When these are involved, the symptoms can include dizziness, vision problems, and even fainting. And here's something most people don't know. A stroke on the left side of your brain affects the right side of your body, and vice versa. So when stroke strikes, where it hits matters. It tells you what abilities might be lost and what can still be saved if you act fast. And recognizing those signs early, that's what we'll look at next. When stroke strikes, your brain doesn't send a loud alarm, but your body does. You just have to know how to read the signs. There's one simple word that could save a life: fast. F is for face. Ask the person to smile. Does one side droop? A is for arms. Ask them to raise both arms. Does one drift down? S is for speech. Can they repeat a simple sentence clearly, or do the words sound slurred or strange? T is for time. If you see any of these signs, call emergency services immediately. Don't wait. Don't guess. Every minute matters. Stroke doesn't always hurt. It doesn't always cause someone to collapse. Sometimes it's just a moment of confusion, or one hand going limp, or a word that doesn't come out right. And that's why people wait. They think it'll pass. They think it's low blood sugar, or fatigue, or just a bad day. But instead of waiting and watching, act. Because the longer you wait, the more brain cells die, and the harder recovery becomes. So when in doubt, remember fast. It's not just a word, it's a lifeline. Now, if you do call for help, what happens next? That's where the first critical scan comes in. When someone shows signs of a stroke and gets to the emergency room, doctors don't wait around. They rush to do one thing first: a CT scan of the brain. But here's the surprise. This scan isn't meant to confirm the stroke right away. It's meant to rule out bleeding. Why? Because blood shows up immediately on a CT scan, while a blockage often doesn't. In the first few hours, an ischemic stroke might look completely normal on the screen. But bleeding? That lights up white like a flare. And this matters because the treatment paths are completely different. If there's blood in the brain, giving the wrong medicine could make things worse, even fatal. So instead of asking, "Where's the stroke?" the doctor first asks, "Is there blood?" If the scan shows no bleeding, they move fast, because now you might be a candidate for a powerful clot-busting drug. But if it shows hemorrhage, the path changes and surgery may be needed. So that simple CT scan isn't just a picture, it's a crossroads. And the next step depends on what it shows or doesn't show. Let's talk about that next step, TPA, and why it's both life-saving and risky. If the CT scan shows no bleeding and the patient arrives quickly enough, doctors may offer a powerful drug called TPA, tissue plasminogen activator. Think of TPA as a clot buster. It breaks down the blockage in the blood vessel, restoring blood flow to the starving brain. It's one of the few tools we have that can actually reverse stroke damage, but only if given in time. How fast? Most people must get it within 4.5 hours of their first symptom. And if you're diabetic, that window might shrink to just 3 hours. That's why every minute matters. But here's the catch. TPA is not without risk. When you bust a clot, you also risk causing bleeding, including inside the brain. If the blood vessels are already fragile, TPA can turn an ischemic stroke into a hemorrhagic one. That's why it's only given under very specific conditions. Doctors have to be sure there's no bleeding on the scan, no recent surgeries, no bleeding disorders. It's a tight checklist because the stakes are high. So instead of seeing TPA as a miracle for everyone, think of it as a life-saving option for the right patient at the right time. And when that window closes, or if TPA isn't safe, what then? That's when we turn to other tools. Let's explore them next. Not every stroke patient qualifies for TPA. Some arrive too late. Others have bleeding risks, recent surgeries, or medical conditions that make TPA too dangerous. But that doesn't mean the door to treatment is closed. The next best step is usually aspirin, specifically 325 milliliters, given to help prevent the clot from growing and blocking more blood flow. It won't dissolve the existing clot, but it helps stop new ones from forming. Now, timing still matters. Aspirin is only given after a CT scan confirms there's no bleeding. Why? Because if you give aspirin during a hemorrhagic stroke, it can make the bleeding worse. In these cases, doctors begin secondary investigations to find out what caused the stroke in the first place. They'll do an ECG to check for atrial fibrillation, an irregular heartbeat that can throw clots into the brain. They may order an echocardiogram to look for clots in the heart, and a carotid ultrasound to spot blockages in the neck arteries. These tests help decide what comes next: blood thinners, surgery, or long-term medications. So even if TPA isn't an option, there's still a roadmap. There's still a plan. And every step is aimed at one thing: preventing the next stroke before it starts. Let's talk about that next. How chronic therapy changes the long game. Surviving a stroke is only the beginning. What comes next is a different kind of battle: the fight to prevent another one. This is where chronic management begins. And it's more than just taking a pill. It's a full shift in how the brain and body are cared for. The cornerstone of long-term stroke prevention is statin therapy. High-potency statins like atorvastatin help slow down the buildup of plaque in arteries, reducing the risk of future blockages. Blood pressure control is next. But here's the key. After the crisis, we lower blood pressure slowly and carefully, often using ACE inhibitors or diuretics to prevent future damage. If the stroke was caused by atrial fibrillation, patients are started on anticoagulants, blood thinners like warfarin or NOACs. But this isn't done during the acute phase. It's a long-term strategy. For most patients, low-dose aspirin, usually 81 milliliters, is continued to prevent new clots. But recovery isn't just chemical, it's also physical and emotional. Speech therapy, physical rehabilitation, and occupational therapy become essential. Patients relearn how to walk, talk, and eat, not just to survive, but to live again. And perhaps the most powerful medicine? Hope. Hope that every effort, every lifestyle change, every rehab session is a step back toward independence. But there's still confusion out there. Some treatments that work in heart disease don't always apply to stroke. Let's clear those up next. It's easy to assume that what works for the heart works for the brain. But stroke doesn't always follow the same rules as heart attacks. And this is where even professionals can get confused. Take dual antiplatelet therapy, for example. In heart attacks, combining aspirin and clopidogrel is standard. But in stroke, we don't usually use both long-term. Why? Because while the heart tolerates dual therapy, the brain is far more vulnerable to bleeding. Using both drugs together after a stroke increases the risk of intracranial hemorrhage, a risk not worth taking unless it's a very specific short-term case. Another point of confusion: heparin bridging. With warfarin, doctors often use heparin temporarily while waiting for the medication to reach therapeutic levels. But in stroke patients, especially after an ischemic event, this bridge can be dangerous. The risk of bleeding outweighs the benefit in most stroke cases. That's why guidelines say, don't just copy cardiac protocols. Understand why stroke is different. Because instead of blindly following what works elsewhere, stroke care demands precision. It demands understanding. So when a viewer asks, why not use both drugs? Or why no bridge? The answer is simple: because the brain bleeds differently. Now that we've covered what to do and what not to do, let's step back and look at the big picture one last time. Stroke isn't a stranger. It's not something that only happens to other people. It's a leading cause of death and disability, especially for those over 60. And yet it's also one of the most preventable and treatable conditions. If you act fast and act smart, we've talked about the signs to watch for, the urgent decisions to make, the treatments that can change everything. But more than anything, this message is about preparedness, because stroke doesn't wait, and it doesn't give second chances. You now know how to recognize the warning signs. You understand why that first CT scan matters. You've seen how TPA can help or harm depending on timing. And you know that stroke care doesn't stop at the hospital door. It continues for weeks, months, even years. And perhaps most importantly, you now know how to protect the people you love, including yourself. Instead of fear and confusion, you have clarity. Instead of delay, you can act, because the brain you save might be your own. If this video helped you understand stroke in a new way, don't stop here. Subscribe to the channel so you won't miss the next video. How to recognize a mini stroke, or TIA, before it becomes something worse. Because when it comes to brain health, the best time to prepare is before the emergency. Stay informed, stay ready, and stay with us. Because the next life you save could be yours.